Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfang, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome to another episode of Breast Cancer Conversations. I am so excited that you are joining us. If this is your first time, welcome. If you tune in week after week, I am so glad you are here yet again for another entertaining episode of Breast Cancer Conversations. Before we get started, I would love to send out a huge thank you to all of our donors, supporters, and sponsors for making our podcast possible, specifically GE Healthcare. Because of GE Healthcare's support, we've been able to go out and find experts in the field and bring you the latest and greatest in content. Where do I even begin? I am so excited for today's episode. I am joined with Dr. Dibble and Dr. Rauch. Dr. Dibble is a radiologist, fellowship trained in nuclear medicine and molecular imaging with expertise in breast cancer imaging. She is an assistant professor of diagnostic imaging at the Warren Alpert Medical School of Brown University. Dr. Rauch is a professor of diagnostic radiology at the University of Texas MD Anderson Cancer Center. She holds a dual appointment in the abdominal and breast departments. Dr. Rauch is the director of molecular breast imaging and the director of the functional imaging lab. Dr. Rauch is a recognized researcher with a focus on the use of advanced functional imaging modalities and quantitative imaging for development of novel imaging biomarkers to improve risk stratification, therapy planning, and endpoint evaluations in patients with breast cancer, rectal, and cervical cancer. Today, we take a deep dive into all of the technology around breast cancer screenings, from MRIs and the traditional mammography to ultrasounds and MBIs. It's all here for you today in our episode.
The most common supplemental screening modality is ultrasound, but that's not because it detects the most cancers of all those modalities. In fact, it probably detects the least of those modalities we've mentioned, with the exception of 3D mammograms, which detect a little bit more than 2D mammograms, but we don't really consider that a supplemental screening modality. That's really becoming the standard of care for women to get 3D mammograms now.
Actually, the way how molecular breast imaging started originally was that this technetium-99 ancestor maybe is cardiac agent. It was used for patients, who are going cardiac stress test by cardiologists. That's something that has been going for, decades. And what they noticed that when they were doing this cardiac stress test and imaging heart, that they found lesions in the breast, that something would light up in the breast.
There's this idea that women get very anxious at being called back from a screening mammogram or needing to have follow-up, which is certainly true, but most women that I talk to tell me they would rather be safe than sorry.
Welcome to the conversation. Thank you both for joining us.
Thank you so much for having us. Happy to be here.
Happy to be here. Thank you.
Dr. Dibble, let's start off with you. If you would like to introduce yourself and where you're calling from.
Sure. So I'm a radiologist, and I work at the Warren Alpert Medical School of Brown University in Providence, Rhode Island. And after my radiology residency, I did a fellowship in breast imaging. So that is, mammograms, ultrasounds, breast MRI, breast biopsies, that sort of thing. And then I went on to do another fellowship in nuclear medicine and molecular imaging, which is sort of different from other kinds of radiology because it's really looking at kind of function and kind of metabolism as opposed to anatomy, which is what a lot of the other types of imaging we do is looking at. And so now I practice in both breast imaging and nuclear medicine and molecular imaging at Brown, and do some research in those areas, particularly related to breast cancer.
Wonderful. Thank you. Dr. Rauch, can I turn things over to you?
Happy to do so. I actually did two residency. Dr. Dibble was talking about doing residency in radiology and then additional training in nuclear medicine. I actually did residency in nuclear medicine, and I also did residency in radiology. And I did this both residency in Houston at Baylor College of Medicine, and I did additional fellowship in breast imaging And then I stayed as a faculty at MD Anderson, where I am practicing right now. And my specific area of interest is, I love breast imaging, I love nuclear medicine also. So this functional imaging, use of these functional imaging modalities for women with breast cancer or for women in general is something that is one of my special areas of interest, let's say that way. And one of my research is about use of functional imaging modalities for diagnosing and treatment of patients with breast cancer.
Wonderful. Thank you. So we clearly have the experts here with us today. And I'm excited because, when I think about breast imaging, I was diagnosed at the age of 34 and I did not have any history of breast cancer. I didn't even have my very first mammogram yet. So when I went in for a diagnostic mammogram because of a concerning lump that I found and advocated for myself to go through and get a mammogram, they were taking so many pictures for a diagnostic, right? I think typically there's 4 and then the 6 and different screens that they're using to kind of look at the nipple and the chest wall and everything. And it was incredibly overwhelming. And then fast forward a couple years, I, was a candidate for a lumpectomy. So now I'm still going through a mammography screenings, every year, every 6 months, depending. And the screening compared to a diagnostic was much less. And so my very first experience was, having so many images taken versus just like a check-in to make sure everything is looking normal, et cetera. So that was my first experience. And so maybe that's a good place to start in terms of informing our listeners about when they are going in for just a regular breast screening. What can they expect in that experience? Dr. Dibble, do you want to start off there?
Yeah, I'm happy to answer that question. So screening mammograms are for patients who have no symptoms at all. So no lumps, no pain, nothing of any particular concern. They're just sort of there to get screened for breast cancer. And we recommend that for women at average risk, they start doing that at age 40, and they do that every year. And so when they come in for their screening mammograms, will typically interact with the mammography technologist. And the technologist will bring them into the room, and they'll get typically 2 pictures on each breast, right? One, we call it in the craniocaudal view, and then one kind of from a lateral view. And then that's it. They'll go home, and then usually, that day or the next day or a couple of days later, their mammogram will be read by the radiologist, and then their report will be ready for them. And that is different from a diagnostic workup, like you were talking about, where if a patient either gets called back from their screening mammogram for something that looked a little suspicious or a little bit of a change on the screening mammogram, and we need to do additional images, or any patient that has any kind of a symptom or is being followed very closely for some particular finding, they would have diagnostic imaging, which means that they would have either mammogram and or ultrasound done for their diagnostic workup, where we do some extra special kinds of views with the mammogram to try to get a better idea of what's going on. And then depending on the finding, they may have an ultrasound as well. And then they typically will get their results at the time of their exam from the doctor. So a couple of different things with diagnostic imaging.
So this all happens in real time while the patient is there. The doctor will look at the images and then make a decision and follow up.
Yeah, in real time. Yeah, exactly. And we may or may not actually speak with the patient depending on kind of what we're seeing. But, if a patient comes in with a palpable lump, pretty much they're always going to see a radiologist who's going to want to come and examine the patient herself or himself and scan the patient directly. So that's not something that would happen during a screening workup.
And I'm always curious too. So what are you looking for when you're looking at these images? Because, I think, and there's probably so many of us on the call listening, and, we're lying there, we're vulnerable, and you kind of get this like X-ray image of your breast tissue. And I'm always trying to look at it and be like, what do I see? What do I see? I know nothing. I can't see anything, right? I see, a lot of white, cloudy areas. I see some, I know they're not veins, but like I see like lines that look like spider webs. And then I also try and like read people's faces. I'm like, okay, do they see something? Like, are they going to give me a clue? So tell me a little bit about in your line of work, behind the scenes, not in front of the patient, when you are looking at the actual images afterwards. Can you give us a sense of that work and what you're looking for?
Yeah, sure. So on the mammogram to start with, so one of the most important things is comparing it to prior imaging. So if the patient has had a few years of screenings before, we always want to make sure we have those available to us because we're looking for any changes. For one thing, any kind of a change, anything on the mammogram that looks like a mass. We basically call anything that kind of takes up 3D space a mass. There are calcifications that we may see on the mammogram, and some of them are obviously benign and we don't have to worry about them at all, but some of them are not clearly benign, so we would want to do some extra kind of workup of those to see what's going on there. And then other kind of subtle things like architectural distortion, which looks like sort of the tissue is almost pulling in a certain area, like pulling to a certain point. That can be a very early sign of cancer. So there's a lot of kind of subtle findings that we look for when we're looking at the mammogram. And you alluded to kind of the gray and the white and the black of the mammogram. So it's basically an X-ray. So that means that the fatty tissue in your breast looks dark on the mammogram and the fibroglandular tissue looks lighter on the mammogram, almost like a white color. And then depending on the density of your breast tissue, it looks kind of the white to black ratio is kind of increased or decreased depending on your breast density. And cancers tend to be that whiter, lighter color, which is why they can be more difficult to detect in women who have dense breast tissue.
Absolutely. And that's a great segue, Dr. Rauch. If I can ask you to kind of expound upon that and let us know, what do we need to know about our dense tissue, breast density? Is that something that women should be aware of going into, breast screenings?
That's an excellent question, Laura, because yes, definitely. Women have different density of the breast, and we have even different categorization of the mammograms depending on how dense their breast is. And when we talk about dense breast, we talk about this ratio black and white that Dr. Dibble was describing. So more white, denser your breast is. That means that you have higher amount of the fibroglandular tissue, and your mammograms looks whiter, which that's what we call denser breast. And why it is important, as Dr. Dibble just mentioned, the cancer also looks white. So if you naturally have denser breast, you have more white on your mammogram. And if there is a cancer, which also usually looks like white, it is more difficult to detect. And this is why for women who have dense breast or extremely dense breast, these are two highest category of the breast density, it is more difficult for us mammographers to detect cancer in women with this breast, with a dense or extremely dense breast. And this is why there is now discussion about possibility of needing of supplemental imaging modality that would help us to detect cancer in the woman with a dense breast. And there is legislation actually about that necessity to put, like when we read screening mammogram, we would need to mention that this patient has a dense breast and inform them about that. And maybe there is which is limitation for us to detect cancer, and they might need some supplemental imaging to further evaluate. And this is whole different topic that, what supplemental, what's the best way to, what imaging modalities can be used. And it's just like molecular breast imaging, actually, one of the imaging modalities that have been evaluated as a supplemental imaging modality for women with dense breasts.
Yeah, that was exactly going to be my next question when we think about supplemental imaging, right? Is that kind of a blanket term to be used in terms of ultrasound or MRI or molecular breast imaging, or is it specific to one of those modalities?
It's more like blanket term. It could be ultrasound, it can be MRI, it could be molecular breast imaging. Yes.
So in your experience, Dr. Dibble got us to this point. She's like behind the scenes, she's looking at these images, she's identifying whether or not the patient has, dense tissue and or if there's reason for concern. Dr. Rauch, at this point, how would you make a determination in what the next supplemental imaging should be? How do you discern if it should be MRI or molecular breast imaging or an ultrasound?
Okay, that's a good question because there is no answer to this question. There is no official approved or recommended supplemental imaging modality for women with dense breasts.
Okay.
So that's a big question for debate. This is a big question for research and, because that is something that has been actively debated and studied in the breast imaging community. And there is, I would say no right answer to that. Dr. Dibble, do you agree?
I agree, but I would add, unless a woman is at high risk for breast cancer, and then there is consensus that the supplemental screening modality should be MRI.
Okay.
So that's defined as a woman with a calculated lifetime risk of greater than 20% compared to the average risk, which is 12%. And so there are multiple, models for calculating a woman's or a person's lifetime risk of breast cancer. And if one of those models kind of puts you above 20%, then you should really be getting screening with MRI in addition to screening with mammography. But there's, for everybody under 20%, which is the majority of women, right? It's about 85% of women are not high risk. That's where we kind of get into that gray zone.
Right. So there's understanding if you're at high risk, there's understanding if you have dense tissue. And I'm sure there's also, resource restrictions as well. And what hospitals have access to some of these technologies plays a factor, I'm sure, in insurance. I mean, there's so many layers, I think, when we're trying to get the best healthcare for ourselves.
That's absolutely right. The most common supplemental screening modality is ultrasound, but that's not because it detects the most cancers of all those modalities. In fact, it probably detects the least of those modalities we've mentioned, with the exception of 3D mammograms, which detect a little bit more than 2D mammograms. But we don't really consider that a supplemental screening modality. That's really becoming the standard of care for women to get 3D mammograms now. So ultrasound just happens to be relatively inexpensive, and it's very easy for breast imaging divisions or departments to kind of work it into their regular workflow. We already are doing breast ultrasounds. It's easy for patients to undergo an ultrasound. So it's kind of very easy to just incorporate into your clinical workflow. So, and we know that we do detect a few additional cancers per 1,000 women screened with ultrasound. So it's a reasonable, supplemental screening modality, but some of these other more functional modalities definitely do pick up some extra cancers that ultrasound and mammography do not.
Can you explain to us a little bit about false positives? This is a term I hear and some concerns people have about these various modalities and supplemental screenings, et cetera, and the potential of receiving a false positive. What does this mean? Can you break this down for us?
Yeah, so that's a great question. And false positives has been one of the big reasons why some of the recommendations sort of haven't said that you need to start at age 40 and screen every year, like USPSTF, which they just came out with their updated draft update guidelines, right? Where they now finally say, yes, start at age 40, but do it every other year. One of the big reasons for that is this concern of false positives. But most of us in the kind of breast cancer community are not as concerned about that, because what that typically means is that someone would, so say you got called back from your screening mammogram, you have to get some extra pictures. The vast majority of the time, it turns out to be nothing. Or it's possible patients may need to get, follow up like every 6 months for a couple of years kind of thing, or may have to undergo a needle biopsy that turns out also to not be cancer. So those are kind of the false positives, with the most common one being you come back in, you get some extra pictures and are told that everything is fine. So I think there's this idea that women get very anxious at being called back from a screening mammogram or needing to have follow-up, which is certainly true. But most women that I talk to tell me they would rather be safe than sorry, right?
100%.
It's definitely a risk-benefit thing. And then as it relates to supplemental screening, definitely some of these modalities have higher false positive rates than others, which may mean, additional follow-up or biopsy that turn out not to be cancer. So that's with ultrasound. That was a big concern when we started doing ultrasound screening back, over a decade ago, because we were kind of biopsying and following more things than we needed to. But once we got, a little more experience, a little more comfortable figuring out which things need biopsy or need to be followed, then those rates kind of came down to it and what we consider to be sort of acceptable rates, where we're not kind of following, everything and biopsying everything and not finding very many cancers. So I'd say reasonable rates now.
Thank you so much for that thorough explanation and helping us understand the pros and cons and the risk benefit analysis, I would say, of the false positives and getting that call back. I completely concur that within our community, we would rather know and, deal with that moment of anxiety than not know. I'd like to turn things over back to Dr. Rauch. Another modality that I would like to dive into is molecular breast imaging. Can you tell us a little bit more about that?
Okay, so that's definitely a very important question. Yes, we need to understand what is molecular breast imaging. That is actually molecular breast imaging, this nuclear medicine imaging modality, or so-called, we call it functional imaging modality, where patients get injected technetium-99m system-AB, which is radioisotope, and this radioisotope is getting taken by lesions within the breast. Actually, the way how molecular breast imaging started originally was that this technetium-99m system-AB is cardiac agent. It was used for patients, who are going cardiac stress test by cardiologists. That's something that has been going for, decades. And what they noticed that when they were doing this cardiac stress test and imaging heart, that they found lesions in the breast, that something would light up in the breast. So there was a lesion in the breast, and this technetium system-AB, in addition to going to the heart, will go to the lesion in the breast, and it turns out to be a cancer. So cancers were detected incidentally in patients who were receiving cardiac scan. So that actually led to development of the molecular breast imaging. Originally, actually, it was called breast-specific gamma imaging because, these cardiac detectors are huge. And, and breast is relatively small. So resolution of these detectors to find lesions in the breast was really very bad. It had to be 2 centimeters lesion in order to be detected. And that led to the development of so-called breast-specific gamma imaging, which is where they develop special detectors just for the breast, and the breast was positioned between the detector and another. It was actually only one detector for breast-specific gamma imaging, and images were obtained just the same way as we do for mammogram. Molecular breast imaging, what we call molecular breast imaging, its difference from breast-specific gamma imaging is that we have 2 detectors there. In breast-specific imaging, there's only 1 detector. In molecular breast imaging, we have 2 detectors practically, and type of the detectors are also different. And the breast is positioned between these 2 detectors just the same way as for mammogram. So we have this craniocaudal view, MLO view. So comparison with mammogram is very easy. And what's most important, there is high resolution because it's dedicated breast imaging now, and we can see very small lesions. Resolution is going to a few millimeters. So very small lesions can be seen with molecular breast imaging. And the difference, I would say, from mammogram is that it takes longer to obtain these images. So for each view, it takes about 8 to 10 minutes. And when we do for the two breasts, all length of the imaging is about 40 minutes, because we need to do two views for each breast, 8 to 10 minutes, 4 views. So it gets about 30 to 40 minutes of imaging time. And final images that we see, they are functional images. So if there is a lesion in the breast, this technetium systemically gets accumulated in the breast, and it's just like flash bulb, And what is also important for molecular breast imaging, the breast density that we are talking about does not matter, because, this technetium is accumulated in the lesion, irrelevant of the density. If it is very dense or not dense at all, the detection of this lesion does not depend on the presence of the fibroglandular tissue or of this whiteness that we see on mammogram. So that makes it, I would guess, special, and this is what makes it so helpful, especially for women who have dense breasts.
Of course. And so, I think the easy follow-up question is, well, if it's easier to see these lesions, why aren't we all doing this, right? And so are there, outside of the false positives that we talked about, are there limitations or concerns someone should be aware of in terms of the radioactive tracer that they're using?
Yes, okay, that's definitely a good question. The major, I would say, limitation or concern that have been raised in general in the breast community is radiation dose, because the technetium-99 systemically is getting injected, so it's a whole body radiation dose, which is then specifically, as I said, accumulates in the breast, but it also, getting excreted with urine and getting excreted through the GI tract. And the concern about the radiation dose, which in general is higher than mammography, has been something that has been raised in breast imaging community. And there has been work done on it where we decreased the dose of technetium-99 systemically that has been administered. We started with 20 millicurie, now we are doing 8 millicurie, and now there is a work on actually halving this dose to the 4 millicurie. And with decrease of this dose, this radiation dose is actually coming closer and closer to the dose, radiation dose of the DBT.
Yeah, that's great to hear.
Yes, so that is something active work has been going on now to decrease this radiation dose, so it is acceptable by the breast imaging community.
Wonderful. And so I'm trying to connect some of the dots here too, because hearing your explanation of molecular breast imaging, and as someone with dense tissue, I want to go back out and say, okay, enough with the mammograms. I just want to get these MBIs. But I think what we were talking about earlier is that this falls also under that category of supplemental imaging, if I understand that correctly, that you would still have your mammography screening, and then in the event that there needs to be follow-up, you could ask your doctor if they would do an MBI also. Am I making those dots correct, or am I missing something there?
Practically, there are two ways to use of molecular breast imaging. It is the way how we are currently is ongoing trials showing that if it is possible to do the like alternating molecular breast imaging and mammogram, for example, to do 1 year just screening mammogram and another year to do molecular breast imaging. That will be a possible option for use of molecular breast imaging. We are not talking here about completely replacing screening mammograms with molecular breast imaging. That's not what the goal is.
I know I always have to be careful because I get so excited, and I know we have all of our listeners. They're like, okay, this is what I want. Is this for me? And so it's always nice to have kind of that context of, still, especially with something like medicine and healthcare, it's constantly evolving. To your point, Dr. Rauch, there's always these trials that are happening. We're learning something new every single day, every single year, especially with all of the great conferences that we're attending, and new announcements and novelties are coming to market. So I really appreciate that. Dr. Dibble, is there anything else we haven't covered that we should let our listeners know in terms of, empowerment, understanding our breast health, understanding the different modalities that are out there, and the role nuclear medicine plays in screenings and diagnostics?
Yeah, we've covered a lot. I'd say I would reiterate that mammogram screening is really the modality of choice, right, for population screening for breast cancer. We know over decades of research how much that impacts the stage that we detect cancers, and long-term improves patient mortality, which, right, we want to catch these cancers as early as possible, so we can treat them, and decrease morbidity as well, decrease side effects that patients have from the treatments. So that's really the number one kind of thing that everyone needs to do. But then we have all these other modalities too that are floating around out there. Like I said, MRI is important for anyone who is at high risk for breast cancer. And then we have these other supplemental screening modalities that like ultrasound for women with dense breast tissue, like molecular breast imaging, like contrast enhanced mammography, that some things like especially molecular breast imaging and contrast enhanced mammography, and something like abbreviated MRI, which might be used for supplemental screening, that really, your access to those may really depend on where you are, right? What the institution has to offer for additional screening or supplemental screening. So those things are not available everywhere. Right now, there are about 30 sites that are using molecular breast imaging in clinical practice. So it's not like every hospital is doing this. So whether or not you can get this may largely depend on where you are and what your hospital is offering for additional imaging, particularly in the setting of women with dense breast tissue.
Sure. Oh, thank you. Dr. Rauch, any concluding words that you'd like to leave our listeners with?
I guess, I would like to thank you for inviting us and to be part of this podcast. Definitely, I can see how confusing it can be a patient, and there are so many, new modalities that are available, and there is such maybe confusion, especially for somebody who is trying to figure out what is best for them. And it's, and about specifically, for molecular breast imaging, which is, functional imaging modality, and it is not available everywhere. I would advise for patients like Society of Nuclear Medicine site, we have actually list of sites where it is available. And on the website of SNMMA, they can see the list of sites where this modality is specifically available, and they can check if this is something that they can use and consult their primary care provider if this is the modality that can be used for them.
That's a really great point. I'll definitely link to the SNMMI website. And then I think you were also mentioning any like clinical trials and stuff too. Like if there's any resources that you think our breast cancer community would benefit from, please feel free to send me an email afterwards, and I'll include them in the description of this podcast and make sure that we get the information into the hands of the people who need it most. So I appreciate you guys taking the time this weekend to be on our podcast, Breast Cancer Conversations, and sharing your expertise and advice and really breaking down some complex topics to answering all of my questions. So thank you so much.
Thank you.
Thank you so much for having us.
And thank you everyone for listening to our show. I would like to acknowledge that all of the information on our podcast are from personal experiences and are not a substitute for professional medical advice. You should always contact your medical care team. Our podcasts are made possible because of donations from listeners like you, so please feel free to make a contribution through survivingbreastcancer.org/donate. And there are so many ways to get involved with our nonprofit and our organization, not just through listening to the podcast, but through all of our virtual programming. So you can check out all of our lineups by hopping over to survivingbreastcancer.org/events. And as always, all of our programs, services, and resources are absolutely free. Thanks again and keep on thriving.